Everybody good? You good, John? Good? Hello, everybody. My name is Robert Longgear. My actual presentation's later. I am pinch hitting here for Jeffrey, who is unable to join us today. So we now have our panel about sort of frontline nurse perspectives on sort of what this means for patients and for nurses who recently been working at the bedside. So I'm now going to take my seat, and we're going to have a wonderful panel discussion here. So first we have Shannon Lunn. Shannon's a research coordinator nurse at the Masonic Cancer Center, University of Minnesota, where she specializes in executing first in human solid tumor clinical trials, bridging the gap between research and patient care. Her passion for nursing and research has led her to co-authoring multiple academic publications, earning certifications as a clinical research nurse and a medical affairs professional. She's currently pursuing her MBA at the Carlson School of Management. Shannon aims to merge her expertise in nursing, research, and business to drive healthcare innovation and enhance patient care. Then we have Mirini Kim. She's a leader in virtual nursing care and is the head of nursing at Pocket RN and part-time faculty at Johns Hopkins University School of Nursing. Her passion lies in empowering nurses to bridge the gap between home and healthcare through virtual care. She is a board-certified pediatric nurse practitioner with experience in both primary care and specialty settings. Mirini brings a unique perspective to the challenges and opportunities of virtual care. She's a graduate of the Johns Hopkins University Executive Director of Nursing Practice Program and co-chairs the Industry and Special Interest Groups Committee of the Commission for Nurse Reimbursement. And last we have Jane Jeppson. Jane is a registered nurse with over a decade of experience across diverse healthcare roles and environments, with a Bachelor of Science in Nursing and a Master's of Business Administration. She has blended her clinical expertise with a deep understanding of healthcare management. Wow, and one thing I'll say about nurses, I'm not a nurse, I did graduate from a nursing school, is that nurses are very well educated. I mean, every nurse I find, lots of certifications, lots of continuing education, so very impressive panel here today. So what we're going to talk about here is the impact of the current reimbursement models on the day-to-day life of the nurse and their patients in the hospital. So that's really our goal here. We know from our previous panels that the current reimbursement model ultimately incentivizes hospitals to sort of minimize that nursing spend, to minimize staffing as much as possible. And so we're going to hear about that from our friends here today. So my first question is, what are the most common challenges nurses face in terms of staffing levels, access to resources, and workload?
Yeah, I think I'll start. Before we dive into current day challenges, I want to go over the mental load that's put on a nurse shift by shift. So I think it's critical to understand that nursing really is a science. I know Rebecca spoke about that this morning. It requires a high degree of critical thinking and education and experience. So the nurse is really the last line of defense for a patient's safety and quality of care. A physician writes orders based off of their assessment, but also the assessment that's been charted that they're reading and what they've heard from the nurse, right? The nurse is the eyes and ears for what's happening with the patient. And so it's critical that they understand not just what to do or what the orders say, or how to do it, but also why they're doing these things. So that as they go to perform these interventions, they're assessing if it's still the right thing to do for that patient. Has the patient's condition changed? Should they be advocating for a change in care with the physician? Was the order that was written accurate or safe for that patient-specific condition, weight, diagnoses, medical history? Did they notice a change that the doctor hasn't heard about? All of a sudden, is their respiratory condition deteriorating? It's really critical for them to understand physiology, pathophysiology, pharmacology, nutrition, so many of these sciences, and so you put that in consideration with the challenges of today, which is increasing acuity level of patients. So we have patients that we, in the past, wouldn't have been able to keep alive, which is incredible, but also obviously makes their care more complicated. We also have workplace violence challenges. So now, not only is the nurse having to worry about the safety of her patients and their acuity level, but she's also having to worry about, is the patient going to try to harm me or themselves? We have mental health challenges that are on the rise amongst, again, patients, colleagues, and the nurses themselves. So that's incredibly challenging. And I think the one that I really want to emphasize is the challenge of staffing turnover and having really young staff and not enough experienced nurses to come and help them in emergent situations. And also not enough time to make sure that you are able to think clearly, critically, and provide that safe care. It's incredibly challenging when you don't have enough nurses to have the adequate time you need to do that safely.
So what I'm hearing is that there's a lot of things you're doing in the daily life, right? You're responsible ultimately for patient care and quality and continuously monitoring patient conditions. You're worried about violence issues. You are sort of juggling multiple patients, 3, 5, 7 patients, some places. So when you don't have enough support, enough team members, how does that impact your ability to do all those tasks that you're doing?
So I can take that one. Just to start off, I want to address the elephant in the room. Between the three of us, Shannon is the only one who's still in frontline patient-facing care. And we had a nurse that was going to join us today, but she got called in because staffing issue. So we're stepping in. And the other thing to note is that we have reached out to our broad network of nurses, and a lot of them were not comfortable sitting here today sharing about the safety issues because they are like, I have to report back to my employers and I don't know what that will look like for my job. So we had a lot of nurses who were very excited that we were having this panel, but they say, I don't feel comfortable going publicly and talking about it. So we're going to do our best to represent what's happening today. And so I wanted just to answer your question, Robert. In addition to what Jane has outlined, which is the top of scope of nursing, there is so much layered underneath that a nurse is responsible for. Nurses do the glue work, right? So anything else that needs to happen to make this patient care happen, they will step in and do it in addition to all of those high level critical thinking things that need to be happening for the patient safety. There's research out there that, for those of us who are here or listening who are not in healthcare, you may see what you see when you're a patient, when the nurse is in the clinic room with you or at the bedside, but there is a lot that is happening behind the scenes that you may not see as a patient or loved one in receiving care. And there's been a lot of research done by medical ethnographers where they have just observed what is a nurse doing during their time at work. And about 60 to 70% of their time is what's called indirect care. So things that they are doing on behalf of the patient that is not right in front of them or at the bedside. And those tasks, again, in addition to that mental load of what they went to school for, are things like charting, right? And what is that for? Documentation for payers. They spend about 23 to 25% charting. Another big time that they spend is coordination. Coordination with who? Physicians, transport, other specialties, all those things. Fetching things, I kid you not, is another big part of it. Because if you want things done, you have to fetch things. And if you want them done quickly, you do it yourself, right? So whether it's getting a cart of meds or whether it's going to find the glucometer because the one you have is out of batteries and they don't have enough for the unit. They just get things done, right? Pharmacy says the tube system's down. What do the nurses do? They go out and they walk and they go get it and they fetch it. And they're doing this while they're juggling the number of patients they have and how critically ill they are. And the list goes on. And I think the thing that's really frightening is that it's not just the things that you see on the surface, is when there are decisions to make cuts on budgets for a hospital and ancillary staff get cut. Who ends up picking up the slack for that? The nurses. It just adds to their load. And so these are the challenges that nurses are facing every day, and we hope that we can represent them well. But it's so great to be having this discussion. So
excellent, thank you. And I mean, ultimately, what we want, I think, as a society and as a non-nurse, as a potential patient, is we want the nurses focused on high-value interventions for patients, making sure that the care is safe, making sure that they're monitoring conditions, making sure that they're catching things quickly. And when you have all these other things going on, or you're understaffed, or you have too many patients, things naturally get dropped. We're human beings, right? I think going off of what Rebecca said earlier around some of the lawsuits and some of the criminal stuff going on, I think around the turn of the century there was a big landmark report that many of you are going to be more familiar with than I am, to Ares Human Report, right? We were trying to bring some humanity to the decisions that were made, to recognize that mistakes will happen, and we need to report them, we need to understand those mistakes, and we need to build a culture that recognizes that that will happen, and we need to sort of own that and make sure that we're addressing and reducing those mistakes instead of hiding them. And understaffing just breeds mistakes ultimately. So with all of these challenges that the nurses are experiencing and having to pick up all of these tasks and making sure that ultimately they're responsible for their patients, so if they don't have support they need, they're still going to get it done. We've seen significant rates of burnout, moral injury, turnover from the bedside role. You two are examples of it, having left the bedside role to go work in other areas. Tell me a little bit more about, what extent that you believe sort of the cost cutting and the staff minimization contributes towards burnout and moral injury.
Yeah, so as I was preparing for this talk, I went and I pulled out some of my old journals, actually. So they were from nursing school, and then also as I was entering the profession. So nursing school, it was really interesting. I talked about how I was so excited to enter the workforce. I was so passionate. I was going to provide the care that is not just physical care, but emotional care. I could not have been more excited. I was just going to provide the best possible experience to my patients. But as I entered the workforce, my journal tone took a pretty dramatic change. I started talking about how my orientation was cut short to just a couple weeks because there wasn't enough staff and they needed me to take on a full patient load. I started talking about how I was asked to take on so many patients at times that I couldn't even remember all of their names. I talked about how I had a full water jug thrown at me, and how was it possible that I was really experiencing burnout after just a few months on the job. So it really is the burnout is just a huge emotional toll. And I felt like I wasn't caring for patients. I was just doing what I could to keep people alive. There was nights where, with less than a year of experience, I was one of the most senior nurses on our floor. And the people that were newer than me, they came to me for questions. And I'm not the exception. There's so much turnover, and it just is not sustainable. You need to just start investing in nurses, because that is investing in patient care.
And Shannon, you told me earlier about a particular situation that occurred where possibly you had cut the sort of patient education department ultimately. Can you tell me a little bit more about that?
Yeah, so the hospital I work at, they recently completely removed the patient education business unit.